Okay, awesome. Well, let's go ahead and get started. Welcome everyone to our GLP training course. I feel like we've been talking a lot about this lately, so we're excited to have put this together and present this to all of you. And I will go ahead and just get rolling with my introductions and agenda and all of that. And we'll try to stay right on task to finish in 60 minutes. It might go a little over with questions. I do leave some time at the end. So as most of you know, this GLP training course is approved for 10.75 CEUs. And my name is Sherry Stoka, and I'm doing the program along with Erica Gutierrez, who she's not joining me for this presentation, but she's going to be doing, some other presentations throughout the course. And we have no disclosures. So before I move on, I just want to make sure that everyone can hear me and see the screen. So if you could just put in the chat, all good, yes, just so I know I can move on and there's not any issues. Okay, perfect. All right. Okay, so again, my name is Sherry Stoka. I am a registered dietitian, nutritionist. I am the owner and founder of Wayless MD. So I opened my business in 2015. I have a certification in integrative health and functional nutrition. I'm a certified LEAP therapist and co-creator of the Wayless RD functional weight loss platform, with which our GLP course is part of. So my specialties are obviously functional weight loss, gut health, food sensitivities, and metabolic health. So what we're going to talk about today is, the course has 6 sessions. So we're going to kind of just touch on, different pieces of metabolic dysfunction. Obviously, we're going to get into GLPs, but really helping you understand what metabolic dysfunction means. We'll talk about GLP receptor agonists and how they work. We'll discuss the mechanism of action and its metabolic effects. We'll discuss different fat stores and how some are resistant to weight loss, learn more about the visceral fat and how it affects the whole body, and talk about ideal candidates for GLPs. And then, like I said, hopefully the last 15 to 20 minutes, we'll open it up and have a Q&A. Okay, so first, our platform is housed in Thinkific. So just make sure that you're logging into that if you haven't already. I'm assuming most people have, but it's pretty user friendly. We are going to be putting the recordings in each day. Well, probably within a day after we have our live session. And all of the Zoom links are already there for each week. So you can just log into Thinkific and log onto the link there. The resources that we provide throughout the course will be housed there. And then we also will have our learning assessment questions for that are mandatory for the CE approval process. And then you'll have access to this for 1 year. Okay, I like to start with this question, and for some people who are doing this course again, they've seen this, but if anyone is brave enough to just kind of blurt out, a yes or no in the chat, I would be really curious to see. So is obesity the cause of all of these things, high blood pressure, infertility, sleep apnea, high cholesterol, etc.? Can obesity be blamed kind of for all of this stuff? So literally a yes or no. We have 1 yes, 2 yeses, 3, 4. Okay, awesome. Thanks for sharing that. So then this presentation might surprise there might be, a little eye-opening as we go through it. So I don't know why. Okay, there we go. So then the next question is, or is obesity the result of all of the metabolic dysfunction, high blood pressure, high cholesterol, inflammation, that type of thing? So that's what we're going to kind of dig into as we go through, but it really take a step back and kind of think about that, because, as we go through, it'll be really obvious, as to what the answer is, but it will help you look at things a little bit differently. So I always like to start with this, and we really don't know the background of all of you, and we're really hoping to get to know all of our um, participants in this program, especially over the course of 6 weeks, and then opening it up for dialogue. But some of the stuff may be very, 101, and some things might be new to you. But I like to start out with just explaining obesity. It is multifactorial. Most people understand this, they understand it, but then they don't really know what that means. But, obesity is, there's multiple things. So obviously the standard American diet is contributing to obesity. Our lifestyle habits, our lack of sleep, the stress that we have, our world is toxic. We are exposed to so many toxins, not only in our food, but also in our water, in our cleaning supplies and our skin care products. So we are really, our body is under attack at all times. Our gut plays a huge role. In one of our other presentations, we talk more about this. Obviously, hormone imbalances come into play, mental health. So essentially, we live in a world that's overfed and undernourished. So our approach, I own a weight loss business, and when I started the business, I always knew that it wasn't going to be just me giving people meal plans and telling them to exercise more and things like that. I knew that there was so much more than that. So I really took the approach of like digging deep into the foundation, because when you get to the root of the body can heal itself. It's not about trying to chase every little marker on a lab or every little symptom, things like that. We really want to get to the root so that we allow the body to do what it was meant to do. Metabolism, metabolic health, I'm just going to kind of go through this, but metabolic health means multiple things. But when you think about just metabolism, it is a chemical and cellular process. It's when the body has to use its, carbohydrates, proteins, and fat and convert it into energy. It's a simple, obviously I'm simplifying it, but so our body needs energy. And it not only needs energy just for us to like move our body, but we need calories for breathing. We need it for circulating blood circulation, digesting food, growing and repairing cells, managing hormone levels, regulating body temperature, etc. So this is like a fine-tuned machine that we live within. And there's so many different components. And when you think about it, if you're not putting in the right substrate, things can go a little haywire. So in this day and age, some of you may or may not know, but it's been estimated that it might even be 100% now. I mean, it's kind of crazy. 90% of, actually, I think it's adult Americans, have some type of metabolic dysfunction. So again, that could mean many things. You have metabolic dysfunction if you have hypertension or hyperlipidemia, hyperglycemia, hypercholesterolemia. Autoimmune conditions is a metabolic dysfunction. Diabetes, mental health, hormone imbalances, inflammation, and gut issues. So we're all dealing with dysfunction. And so when you take a step back and think about like us as dietitian, nutritionists, or providers, practitioners that are helping people lose weight, we have to think about things differently, because the body is no longer in a state of like a 10-year-old kid, when we were 10 years old, maybe we were healthy. So if we were eating too much, or gaining a little weight, we actually probably could address it just by eating less. But now things have entirely changed because of what has happened to the health of the human body. So you get out what you put in, which is obvious, but I do feel like we often neglect really honing in on the diet because we hear about, oh, I'm eating protein, I had some pasta, or I had vegetables, but what we really don't realize most of the time is that all of that, even though it sounds good, is probably processed. So, really just kind of thinking about taking like your practice to another level of really just getting people off of the standard American diet. And that in itself is going to get the body to start, to start healing. All right. So the obesity narrative is insane to me. Everywhere you go. American Heart Association, American Diabetes Association, and it's probably, the American Academy of Nutrition and Dietetics. I mean, we are all saying the same thing. Obesity increases your risk of high blood pressure, high cholesterol, heart attack, cancer, et cetera, et cetera, et cetera. And actually, that's not the truth. I mean, the reality is that obesity is not the cause, it is the result. It is the result or a symptom of long-term metabolic issues. And I'm going to, continue to kind of help you wrap your head around it. But if you kind of think about it, well, I'll wait for the slide before I go down that rabbit hole. But over time, you might have developed some type of metabolic dysfunction 10, 15 years ago, and your body's just adjusting, your things are slowly altering. And now you get to a point, say 15, 20 years later, you no longer, you no longer can lose weight, you're fatigued because your body has started with a low-grade metabolic dysfunction and then continued to get worse. So the point is, obesity, think about it. Obese people do not go into the doctor and get put on high blood pressure meds or high cholesterol. They got put on that a long time ago. So over time, the dysfunction just resulted in obesity. So this is a really important piece. And until you really understand that piece, it's going to be really hard to help people who are overweight or obese. So the body is out of balance. And we do a very comprehensive body composition testing all throughout our programs. I understand that not everybody has access to this, but I do encourage everyone to find a way or collaborate with somebody that you can send your patients to, because if you don't know what a patient is losing when they're losing weight, you really don't know if you're helping them, because I mean, if they lose a ton of muscle, you're actually putting them in a worse metabolic state. So you can see maybe you can see it. I mean, it's kind of blurry, but so let's just look at this for a second. We have this patient who weighs 223 pounds and muscle mass is 68 of her weight is muscle mass, 101.9 of her pounds of her weight is body fat. So we know that this is pretty accurate, that there's approximately 3,500 to 4,100 calories in a pound of fat. That's like when we were in school and we learned this. And, if you just reduce your calories by 3,500, you would lose a pound of fat. So we know that that's like a complete joke. But in theory, it kind of makes sense. So if you look at this particular person and you do some calculations, you would assume that they have over 400 calories stored in their body for use, because that is what fat is there for. So why does weight loss stop? Why do people go on these low calorie diets and within 2 weeks or so, the weight loss stops? It doesn't even make sense. But that's why understanding metabolic dysfunction is crucial. So the first piece is, oh, whoa. The first piece is the fat cells. And all fat is not the same. I'm sure we've all heard about brown fat. Maybe you've heard of white fat cells. But this is a very simplistic view of what those cells look like. And the white adipose tissue, so you can see that there's the mitochondria, there's not many. It's a very large fat droplet. The cell nucleus is small. It is designed for storing calories, whereas the brown fat cell is full of mitochondria. It has small little fat droplets. It has a healthy nucleus. And so the function of these fat cells are very different. And I'm not going to go through this entire image right now, but you can kind of see and look at this later and compare the white adipose tissue to the brown and to the beige. So white would be kind of like your visceral fat, the fat that gets kind of trapped around the internal organs. Some other important things, it releases many different inflammatory compounds, which again, we'll talk more about, but because of the nature of the fat cell, it actually has the propensity to affect almost the whole body because of it almost becomes like in the visceral becomes an organ of its own. So again, it is for energy storage, glucose uptake, etc. Whereas brown adipocytes they're thermogenic. They're for lipid clearance. They actually help your body burn more fat. And then you have the beige adipocyte. So this is kind of like a neutral fat cell, whereas it has the propensity to either go to brown or go to white. So when you hear like HIIT exercises or cold plunges, or what are some of the biohacking things, intermittent fasting, those type of uh, lifestyle things that people are doing can actually influence the beige adipocytes. So it can turn to brown, or if you're lazy, not doing much, it can turn to the white. So understanding just the differences in the fat cells is really important. So we have subcutaneous fat and we have visceral fat, right? Subcutaneous fat is the pinchable stuff. We don't like it, but it's actually not, it's not really damaging to our health. It doesn't cause the inflammation like visceral fat does. So the main things that visceral fat does is it causes systemic inflammation, it increases insulin resistance, and it signals, it totally influences different hormones in like your hunger hormones, your stress hormones. So that's why people are just nowadays are just they're craving certain things. So they can't handle stress because their stress hormones are always elevated because of their state of health. So it really is affecting so much more than just their ability to lose weight and obviously, not looking great. So this image, okay, so we have, I like to give like it a little analogy to help people kind of understand that like the white or the visceral fat, that is in your body. It is stored energy, but it is not accessible. Your body cannot use it in a time of need. It's just like if you think about a freezer and a refrigerator. If you're starving and you see the food is there, but it's frozen, you can't eat it. So the goal, even in our body, is to be able to transport the certain fat cells, or in this case, the food, into a place where it can be used readily for energy. And I'll talk a little bit more about that. All right. So getting to the root of the root of the root, where does this all begin and why are so many people struggling? Well, it all starts with the blood sugar variability, the glucose variability. And, a lot of it has to do with the standard American diet that is just nutrient depleted, full of sugar, full of stuff. Because if you would just eat food, like real food, you're not really going to get these extreme fluctuations. But nowadays, it's like everyone is on the standard American diet. Nobody has any idea what's going on with their blood sugars all, throughout the day. And so this variability, these ebbs and flows, these spikes and the lows is destroying our metabolic health. Because again, for those of you who this might be very simplified, but I like to just kind of go through like a simplistic process to help everyone kind of be on the same playing field. Blood sugar fluctuations, obviously, when you have sugar in your blood, the body does not like that. So, when there's excess sugar and you have blood sugar fluctuation, the pancreas is overworked because it's got to keep pushing out insulin to clear the sugar. So now, your cells no longer respond to the insulin. So more insulin is being pushed out because it perceives that more is needed. In fact, when the sugar is still staying in the blood, and this sugar begins to build up, and the body has a way of getting it out when the insulin cannot transport it out. And so what it will do due to the process lipogenesis, the liver will actually convert the sugar into triglycerides and transport it into the fat cells as white adipose tissue. So usually that's transported obviously right around all the vital organs, the liver, the pancreas, the gallbladder, the kidneys, in that main area. I always wonder why that's the main area, because it's so vital, but I don't know. Maybe because our body, again, kind of going down the road of like the body is so smart. I'm not really sure why it does that, but so this process happens over time and just continues to happen because, again, of the blood sugar dysregulation. And visceral fat actually does become almost a new organ in itself, because it can start to produce its own fat cells. It can start to produce different hormones. It produces cytokines, which are inflammatory compounds. So the visceral fat is a destructive organ. So I kind of already said it, but it secretes hormones and chemicals that affect the whole body. It secretes leptin that controls the appetite. That's why we see this appetite dysregulation. It secretes adiponectin, which affects blood sugars and fat metabolism. It produces cytokines, which causes inflammation, and angiotensin, which increases blood pressure. So it does a lot of really, really bad things. So always going after visceral fat is super important. So now it's an organ on its own, and it becomes resistant. So even though there's a lot of fat stored there, it is kind of like the freezer food. And the reason why the body will not use that, it may use a little bit, and some may be freed into the mitochondria to be used, but for the most part, the body protects itself because it is so inflammatory, and it actually is the dumping ground for most of the toxins that you can't get rid of through your detoxification system, because our liver that's why people have fatty liver, right? I mean, it's overburdened. Our liver's not functioning. People are taking their gallbladders out because that's all congested. And so all of the toxins basically just sit there. So people never really get out of this metabolically imbalanced state. And that's the reason why, I mean, just lowering calories does not work. And usually you're lowering your calories and you're still eating the standard American diet. So then that surely is not going to work. So, and it gets worse because of the inflammation in the body. most people are walking around with low-grade inflammation. Some people are walking around with high-grade inflammation. And these these inflammatory compounds disrupt the metabolism of lipids and blood sugar. And then when you think about inflammation, we have all learned that inflammation is crucial. It is such an important mechanism in our body when we need healing to happen. So if you cut your leg open, and the natural mechanism is an inflammatory response, which that signals to the immune system, hey, we have an injury, recruit in all the T cells, the helper cells to heal that. And so what happens now is there's so much inflammation that the immune system is confused because the inflammation never goes down. So it doesn't get that feedback loop of, okay, inflammation, now back to baseline. The inflammation is always there. So that's why, autoimmunity is taking it's increasing leaps and bounds. And it all comes back to this whole process, the metabolic dysfunction, the gut issues, and 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 the food that we're consuming just feeds into it. Okay, so now we're going to switch gears a little bit. Now that hopefully you kind of understand a little bit about metabolic health and why people have a hard time losing weight. So GLP-1 natural, our endogenous GLP-1 is a human incretin hormone derived from the proglucagon molecule. So our incretin hormones are gut peptides secreted after we consume certain nutrients. So we're going to get into this later in the courses, but just think about that. Again, I don't want to go down too much of a rabbit hole, but so this is natural process. We eat certain foods. Usually it's, fiber. It's usually some type of carbohydrate. It's kind of like different nutrients that we don't really get in our diet now. But it's designed for the GLP to be activated when we consume that food. And what then happens, it stimulates the insulin to help regulate the blood sugars. So it has an effect on the glucagon and the pancreas, and its main job, as an incretin hormone, is to regulate glucose homeostasis in the body. So when you're working with, there's many studies now and it's so obvious now that GLP-1 secretion from the gut is significantly impaired in obese patients. So that's why now, we're seeing like people start these and it's a whole new world opens up to them. Now, the exogenous, so the medications, the injections, agonists share 94% structural homology with the human GLP. And so that's pretty good. And so they were designed to kind of mimic what is supposed to happen naturally. So these medications will activate the GLP-1 receptors in the gut, the pancreas, in the brain, all different areas, which we will talk about, but I think most people know that there's receptors everywhere in the body. The primary mechanism for weight loss is the effect on the brain, so the appetite suppression, the delayed gastric emptying, and then obviously the insulin secretion, because so many people are insulin sensitive or insulin resistant, and all of a sudden you get the beta cells to start producing more insulin, and you see things turn around. So so the GLP-1 agonists have been on the market for 20 years. And you can see that, so it started in 2005. I'm just going to highlight some things here if you care to go back and look at it. But some important things here, 2005, they had Byetta, and, it came out as treatment for type 2 diabetes. The dosing frequency has changed significantly, and that was intentional because of just the practicality of patients taking these injections. So it started out in 2005 as a twice daily injection. that didn't go well. People were not into doing 2 injections a day. So then they got to doing like once daily, and then now, once weekly is now is the preferred and the updated medications that are out there. So you can see in 2021 is when like Wegovy came to market. So Wegovy was the first GLP-1 approved for weight loss. So Ozempic is basically the same exact compound, but it's approved for type 2 diabetes. So there is a slight difference in the recommendation of dosing, but again, I know this is kind of common sense, but Ozempic and Wegovy are like almost exact. They're like the exact same product. And tirzepatide and Zepbound and Mounjaro are also pretty much the exact same product, except Mounjaro is for type 2 diabetes and Zepbound was approved for weight loss. So they have evolved. We eventually talk about what's going on in the future, but you can see the big thing with these GLP-1s is that they started out as a single agonist. So Wegovy, Ozempic is a single agonist. It acts on the GLP receptors. And then Mounjaro comes around, the tirzepatide, meaning the compound in these products, is a dual mechanism. So now they're affecting the GIP receptors and the GLP. Okay. And again, we talk more about this, but it's introducing it so you can kind of wrap your head around the differences right now. And then the newest product that it didn't hit the market, it's in studies right now, is retatrutide, and that's a triple agonist. And then there's one that is in the pipeline, which is a quadruple agonist, hitting 4 different receptors. So it's this area of medicine is just forever evolving, but you can see how quickly it's grasping and kind of taking over in so many segments of healthcare. I mean, even beyond weight loss. But the big thing that I wanted to point out too is because when I first started to look into the GLPs and I wanted to know like what the heck was this stuff? Was it safe? Is the body recognizing this as foreign? Like, are people going to have an immune response? And so I wanted to know the difference between the native GLP versus the GLP that we were injecting into people. And so when you look at the native GLP, you will see that the half-life is 1 to 2 minutes. Okay, so you consume food, that nutrient senses to the GLP hormones. The GLP hormones are signaled to all the receptors throughout the body, does its thing, and then it goes back down to baseline. Okay, so the half-life of semaglutide is 165 hours. Okay, so we're talking 1 to 2 minutes, half-life, 165 hours. So that's not natural, right? So then you kind of wonder, okay, this is pretty big. But so when you inject the GLP-1, it's going to signal to all of the receptors and it's going to stay elevated for 7 days. And so you have to kind of wonder, that really is much different than normal physiology. So as we continue to learn more about these GLPs, we are asking some questions, and some questions are still not answered. And we do know that the GLPs, the semaglutides of the world, have been on the market for over 20 years. And there's, good sound research as far as long-term, no detrimental effects, but you start to question maybe like the dual mechanism now and then the triple and all of that, because that hasn't been on the market. But the questions that we still ask is, we know that they don't mimic normal physiology. We still have questions about the long-term effects of the receptors being constantly signaled. So, are those receptors going to become saturated? Is that why people on these medications, eventually the weight loss stops? Because plateaus are very real on these medications. And then the other thing is, does the body recognize it as foreign? There were some studies done on semaglutide, the semaglutide compound, and it showed that the immune system was not triggered by it. So I don't think that is a problem, but as these evolve, it's something to kind of think about and even start to watch like autoimmunity and things like that, because the last thing we want to do is treat someone for obesity and then, start a whole new, autoimmune type of condition. So again, just to reiterate the main mechanisms for weight loss, the GLP-1s, they act on the pancreas to stimulate insulin. So obviously that is great. I mean, that is going to help a lot. It's going to signal to the GLP receptors in the brain that controls the appetite, and then it slows gastric emptying. Most people are saying in your short kind of description, it enhances fullness, which it does. But when you slow gastric emptying or gastric motility, that's really what's kind of contributing to a lot of the side effects that people are experiencing. But it does have some benefit to it. It's not just about the fullness. When gastric emptying is slow, the fat is exposed to pancreatic lipase for longer periods of time. So you do get more breakdown of triglycerides into free fatty acids, and it's the free fatty acids that actually can move into the mitochondria to be used for energy. So it does allow for that process to improve. And the slower rate of emptying also helps to regulate the absorption of the glucose as well. So obviously you're not going to get the huge spikes that you normally would get under just regular eating standard American diet without the nuts. So I would always ask, I would always want to know, like, okay, if these GLPs are so incredible, they do so many good things. I mean, there's a trillion studies. I think there are so many studies on GLPs, and like they're all positive. And it's like, okay, so if they do so many things, like why can't we stimulate, activate our own GLPs? And I think it's probably kind of obvious by now, but because of the gut issues, because of the diet, we're not getting the appropriate nutrients. The diet is causing all of, these gut issues. Leaky gut decreases gut hormones. So we're having not only have a decrease in gut hormones, but we are not eating the food to actually stimulate it. The inflammation is basically blunting the receptors on the cell. So it actually, you can't even though you might get the signal, the receptor is blunted, so it's not going to perform that mechanism. We have reduced enteric neurons, and again, the excessive visceral fat is just causing the whole host of things to continue to exacerbate. So do GLPs improve metabolic health? I mean, they do. Yeah, I mean, they improve insulin resistance, they improve the GLP signaling, they improve energy balance in the body, and they're shown to decrease inflammation. So the question is that sustainable? So of course, it is. Well, again, I'll just move to my next slide before I kind of get long-winded. So when you think about what the GLPs do, and just a simple case, and this is probably so obvious, but it's just, again, just looking at things a little differently. You put somebody on a low-calorie diet or, 1,500 low-carb diet. You're telling them to exercise 3 times per week. Maybe you give them a couple supplements. Then you have another person, you're doing the exact same thing, exercise 3 times, couple, supplements, and then you give them the GLPs. And the GLPs is an absolute game changer. Whereas people that are so dysfunctional with inflamed cells, GLP resistance, insulin resistance, they're not going to respond to that 1,500 calorie diet because they're in that dysfunctional state. So that's where the GLPs are just supporting all of those missing links that are no longer happening in the body. And there's other benefits. You can see, I mean, we have GLP receptors in our mouth, our fat tissue, our muscles, obviously our pancreas, our bones, kidneys, liver, it's everywhere. And they do a number of positive things. We've seen some big things that we've seen is a decrease in pain, a decrease in food noise, increase in energy. People it's almost like their depression is resolved because there's something, obviously that has receptors in the brain that makes people feel better. There's research looking into why this is helping people give up certain addictive behaviors, whether it's alcohol, whether it's drugs, whether it's just, food addiction. It's literally changing those addictive behaviors. And it's also shown to increase sleep. So who is a candidate? The obvious: prediabetes, PCOS, fatty liver disease, dementia, weight loss resistance, autoimmune disease. Or could it be anyone with metabolic dysfunction? So I'm bringing it back around, right? So bringing it back around with, let's say you're 130, you're healthy. 5 years later, you gain some weight and you're put on a medication, right? So now you have some type of metabolic dysfunction. So, 2-3 years later, you go back to, you're back at the doctor's office again, and now he puts you on 2 more medications. And then, you come back and, now you're over 200 pounds and everything's a disaster. You have autoimmune disease. So the whole point of this is, if we can see early on that there's some early metabolic dysfunction going on, I feel that that these can be used not in the dosing. We play with it in so many different ways, but the most important piece is not only, oh, let's get someone on GLP super early. It's more like, let's identify the metabolic dysfunction early on and start having those conversations and just set expectations with patients, meaning now that your body can no longer manage appropriate blood sugars or blood pressure, we have to get your body into that healthier state. Then weight loss will be more manageable for you. So who is not a candidate? Let me make sure I'm on time here. Oh, okay, I gotta hurry. Personal history of medullary thyroid carcinoma or patients with multiple endocrine neoplasia. So pregnancy, inflammatory bowel conditions, although you don't have to entirely rule it out because there are some studies showing that it helps, like Crohn's patients and things like that. Pancreatitis, be very cautious of. Gallbladder disease, be very cautious of. Gastroparesis. If someone's getting surgery, you need to get off of them and then stay off of them 2 to 4 weeks before and after. And then obviously precautions with women and anyone that's already dealing with severe gut issues like constipation. Okay, so things to think about when you're seeing patients. What do you do when you think a patient is not a good candidate, but was referred to you for helping the management for the patient, nutrition wise? What would you do if a patient is not losing weight? What would you think? What to do if you think the patient is on the wrong dose? Are you prepared to kind of have the dosing conversation? What to do if the patient has significant gut issues but still wants to stay on the medication? What are the patient's weight loss expectations versus your weight loss expectations? And can you explain the pros and cons of the different GLP medications? So just, again, we always end with like just some things to kind of think about that, we're, hearing, almost daily. So summary. GLP agonists are peptides that are aimed to mimic normal physiology. So we kind of know that it's not exact. They improve metabolic dysfunction. GLP-1 agonists can improve other disease conditions when applied correctly and in concert with other foundational interventions. They can treat obesity and prevent obesity, but you must be metabolically healthy to sustain the benefits. The benefits can far exceed just weight loss, and we definitely still need long-term data with the dual and the triple agonists that have been on the market now. And then when you go into Thinkific, there will be a couple resources for you that hopefully you find very helpful for your use. And that is it. I think I'm going to pause and restart for the questions. Okay, so I am going to open it up. If you want to unmute and ask, if you want to put something in the chat, you can do that as well. Okay, no questions.
No, Sherry, I actually have a question. Can you
Oh,
hear me?
good.
Okay. Oh, you know what? You can't see me. Hold on. Not that, although I'm not prepared to be seen. Uh, so I'm just curious, in the practice you're at, I mean, I know you're an RDN, like most of us are, you're not an MD. So are you working with MDs to recommend various GLP-1 medications?
Yeah, great question. So my practice is on medical weight loss. I actually am the only dietitian that I'm aware of in the US that owns a medical weight loss business. So we have a supervising MD, and then we have I have a couple of nurse practitioners on site. So we develop protocols, and then we kind of can follow various protocols, but then as far as like, starting patients on GLPs, and then we're the ones like, seeing patients and managing them for the most part.
So do you have a decision tree for how you decide which GLP? I mean, I feel like there's a new one coming out every week. If they're going on a double agonist, a triple, the quadruple, how does the oral work versus the injection? Like, do you
Yeah.
have a decision tree that you use?
So ours is pretty simple because of what we have on site. So we don't use the oral. I wouldn't really start with oral because I know they have a lot more side effects. So we have semaglutide, tirzepatide, and retatrutide. And we usually always start with semaglutide, the single agonist, unless somebody has significant gut issues. Tirzepatide is known to have less side effects, and we actually do see that. So if it's kind of like, everything else appears to be similar, we are always starting with semaglutide because you can always go to tirzepatide. Tirzepatide is more expensive, so it doesn't make sense if, to start with the more expensive one, so that's kind of how we manage that in our practice.
Okay. I mean, it's interesting to me because I probably know 10 people, they're not under my care, who are on, and all of them are on Zepbound. So I don't know if that's a function of where people are located in the US. And these people are vastly different in their body size and in their metabolic health, but they're all on the same product.
Yes. So the studies that came out showed semaglutide had, I think it was 15% weight loss. Studies came out for tirzepatide, the weight loss was 20 to 25%, and then retatrutide was like 25 to 30. So I think that people are prescribing tirzepatide more because of the studies showing more weight loss.
Okay.
And yeah, I think you're right though. I think it really depends on like your area. It depends on like your access. It depends on, because now people are switching because it's like, what's available now? What is insurance covering? What's cheaper? There's just so many variables now.
Right. Well, of course, as I obviously Medicaid and Medicare, they're not covering this at all, no matter what anybody's health status is, and no matter how they have been resistant to weight loss, and no matter what their metabolic situation is. So, if people have the resources, they're getting it direct. Of course, they still have to have a prescriber, but they're getting it direct and paying out of pocket. And needless to
Yep.
say, there's compounding too.
Correct. Yeah, and that's where we get ours compounding. Listen, there's a lot of corruption, right? I think we all understand that our healthcare system is designed to be profitable without a doubt. So people are jumping through hoops and, are we doing the best that we can for people that, I have some people that they're 140 pounds, they're at their normal weight, they're getting it covered by their insurance. Whereas the next guy down the street has type 2 diabetes and it's not covered. So
Okay.
it's the wild, wild west. None of it makes sense. And it's forever changing and evolving. And there's a lot of people out there fighting because we need some structure because it doesn't make sense. This is helping a lot of people, and the people that need it the most are not getting access to it.
Okay, and this question might be something covered in future modules. But are you doing anything in your practice to prep people uh, before they go on it? For instance, obviously, I know you're familiar with the GLP-1 probiotics and supplements that are derived from bitter plants that help to curb appetite. I mean, and now I feel like I get an email a week, maybe more than a week now. It's like every other day from a supplement company about either a supplement they're recommending to prep or supplements to take along with, the polyphenols, et cetera, and different things because of possible nutrient depletion. So maybe you said this already. Will you be covering that later on?
Yes. Yeah, because that's a super loaded question.
Yeah, I know. That's why I asked it.
Yeah, yeah, it's super, and we do cover it.
Great.
I'll kind of just leave it at that, but we're big into supplements. We definitely don't. What I will say is we don't use like the GLP boosters when they're on GLP. We're working on other things. We're working on cleaning up the diet, making sure they're getting fiber, like their metabolic, like we're supporting a lot of like the foundational stuff. If they're on, and then we love the GLP boosters for like when they wean off of it. We find that to be really helpful.
So when you say GLP booster, are you talking about like CaloCurb and things like that? Or
Yeah.
okay,
Yes.
okay,
Yeah.
terrific.
Yeah. All right. Anybody else have any questions? Let me look in the chat if there's any. Okay, everyone. Well, if nobody has any other questions, we will end it here. Thank you so much for joining. I hope wait, we did get something come through. Please share compounding pharmacy. What do you want to know about the compounding pharmacy? I know a lot about compounding pharmacies. I don't know what your question is.
Hi, Sherry. Just wondering any specific pharmacy you use to order your medications from, including Wegovy or Trizeptide.
Well, I work with several. I work with New BioAge. I work with Olympia. I work with uh I don't work with Texas Pharmacy anymore. What's the other one? Why am I blanking? I mean, I've researched. I mean, I think the most important thing about compounding pharmacies is knowing the credibility of the compounding pharmacies.
Mhm.
Because
Sure,
this
sure.
truly is the wild, that truly is the wild, wild west, especially,
Mhm.
you know, during this time when like, you know, when it was on the shortage list and anyone was offering it, it
Mm.
was scary. So, and I can put a short list together of like credible companies, but doing your due diligence is going to be,
Yeah, because I see online there's so much. You know, some people are saying you can get this and this medication for only $100, 122 something, and then I doubt it. Is this a real or something else going on, you know?
and you have to ask for the certificate of analysis. You want to see
Mhm.
what's in their product. If it's cheap, it's cheap. I mean, if
Yes,
it's cheap, there's
definitely.
a
Yeah.
reason why. It's just like
Yeah.
buying, you know, a supplement from Walgreens. It's cheap because it's full of stuff and it lasts forever, and it's the same, you know, same story.
Yeah.
Yeah, you
Thank you.
get what you pay for.
Yeah,
That's true. Yeah.
yeah. But I love New BioAge. They really they offer a lot of support and education to practitioners.
Mhm. Okay.
Yeah.
Thank you.
You're welcome. All right. Last chance. All right, everyone. Thank you so much. We'll look forward to seeing you next week. And don't forget to fill out your assessment questions. Would love to hear what you thought. And yeah, have a great rest of your day.